So my case is the hanging stent or the dislodged stent, and how reverse cullotte saved the day for me. So this gentleman is a 65-year-old male, known hypertensive, and presented with acute onset chest pain since 1 day prior to admission. On examination, his vitals were stable, and all other systems were having no other abnormality. Echo showed an ejection fraction of 42% with hereditary hypokinetic, no MRAR or TR was present, and ECG was suggestive of ST coving with T inversion in V2 to V6. Now, patient was explained for angiography and revascularization, and under informed consent, a patient was taken for angiogram. On angiography, we could see that there was a lesion from proximal to mid-LAD, especially tight at mid-LAD level, 95%. Then there is osteoproximal diagonal, and it is a long segment disease. It was 99% critically diseased with a thrombotic burden as well in this. Distal LAD also showed a critical disease, and RCA and LCX were normal with mild plucking only. So now, initially my plan was I wanted to do a bifurcation strategy only because diagonal was looking big enough. But since I didn't know the size of the diagonal initially, I didn't go for a DK crush technique or mini crush technique. I thought I'll go with a tap technique. So with a right radial axis and EBU 3.06 French, a run through NS was passed into LAD. Whisper extra support wire was taken into first diagonal. And to secure this diagonal, since it was thrombotic, I first pre-dilated first diagonal with 2.0 into 10 mm semi-compliant balloon at 6 atmosphere around, so that detection might not happen. And if it comes out to be a small vessel, I may not stent it, and I will just do FKBA and come out. So I took a 2.0 into 10 mm semi-compliant balloon, dilated the diagonal ostia at 6 atmosphere, then dilated high pressure, so as there might not be any defection, and if the vessel come out to be small, I may leave it and just do FKBI and come out. So dilated D1, and then the LAD also with the same balloon, 2.0 into 10 mm semi-compliant balloon, mid LAD was dilated with that. A 3.5 mm into 48 mm DES was taken into LAD. It was a Hanging Stent, Hanging expedition. And after positioning it, it was dilated from proximal to mid-LAD. There was adequate distal flow, no distal dissection was seen, though the distal lesion was still there. But I first of all thought that I'll secure the diagonal, because here there seemed to be some dissection in the ostial diagonal, and the ostia also got severely pinched. So I thought that I'll secure the diagonal and went on with the tap strategy. So first of all, the wire was taken out from the diagonal. Diagonal was flowing. Pot was done with 3.75 into 10 mm NC balloon at 14 atmosphere in the proximal LAD. Diagonal was recrossed with Whisper ES. Keeping a 3.5 into 10 mm NC balloon in LAD, and post-dilating the LAD stent also with the same at 12 atmosphere. Now I took a 2.5 into 28. First of all, I dilated the diagonal stent, ostial diagonal, and LAD stent strut with 2 into 10 mm NC balloon, so that my stent can easily pass through via the LAD stent strut into the diagonal. Thereafter, I took a 2.5 into 28 mm DES stent. This was also Zions into diagonal. Now, at this point, actually, nightmare started. I was just pushing and pulling so as to reposition this the diagonal stent, keeping only 1 to 2 struts into the LAD, so as to go ahead with the tap technique. But meanwhile, it was quite a restrictive movement. So while doing so, the shaft of the stent broke from the soft part. Actually, the stent has got 2 softer parts. So the most proximal part, it got broke from the stent, and the stent with its balloon and a small part of the softer part was lying inside the diagonal, and a bit of it back towards the left main. The stent was lying uninflated, hanging in the diagonal now at this point. So what next? What needs to be done? I could have there were few options. I could have snared the broken stent. I could have balloon trap and removed the whole assembly. I could have used another wire and twisted it and thereby removing the stent, the hanging stent. And crushing of the stent was taking a new stent and crushing this previous stent was out of question, as softer part was still there inside, and the balloon was also, stent balloon was also there inside. So this point, at this point of time, this method was not appropriate. So I thought that since I have already a balloon inside the LED, I'll take it out and dilate the guide catheter and dilate it at 6 atmosphere, and thereby I'll remove the whole assembly at this point of time. So the LED balloon of 3.5 mm, it was taken back into the guide, dilated at 4 atmosphere, and whole assembly was pulled out. But unfortunately, at this point, what happened was the uninflated Devon stent that got stuck within the LED stent strut, while the balloon with a bit of soft part and the wire, they came out. The diagonal stent here got crumpled into the LED stent, and a part of it was stretched into the diagonal uninflated. I lost the access to both the vessels. The wire was not there in the LED. As I pulled out, I thought I'll pull out the whole assembly. Initially, I thought that the idea here was that the diagonal stent will not get, I didn't think that diagonal stent will get stuck into the proximal LED stent struts, and I would rewire the LED stent easily if the diagonal stent comes out. But unfortunately, this thing happened. So now what next? This shot was taken, and both the vessels were flowing, and patient was hemodynamically stable at this point, fortunately. But my diagonal was actually dissected from the osteoproximal part, and there were crumpling of the crumpled stent struts present at the proximal LED, which is nidus for stent thrombosis, definitely. So for my first aim, I thought that I'll salvage the LED first by rewiring it and dilating the stent struts. So now at this point, I was trying to maneuver my wire through the LED stent strut, but it was not at all going. It was always going behind the LED stent struts, not at a single point that it went inside the LED wire. And I could also see it, that it was going behind. A curve was being formed, actually. So, and every time this whisper wire was going inside the diagonal stent, which was lying uninflated. So I changed the strategy. I thought that I will go into diagonal. I will dilate the stent struts thoroughly, and then we'll pass on the wire into the LED and do an FKBI and come out. But so now we'll see the next steps, what was being done. Whisper, it crossed the diagonal, uninflated diagonal stent. With further maneuvering, LED wire could cross and parked into LED, but I didn't know whether it was through the lumen or it was behind the stent struts. So I took a 1.0 balloon into LED, but it was not crossing through. So this proved that it was, see, in this video also we can see that the LED wire was actually behind the stent strut. With a curve it was going. So it was not in true lumen. And no balloon could also actually go through this. So LED wire was behind the struts. It was removed. Now the plan was to dilate the diagonal stent struts. Devon stent was dilated first with a 1.5 into 10 mm NC balloon, and subsequently with a 2.5 balloon. This was also a wrong LED wiring, actually. So I continued with my Devon stent dilatation with 1.5, 2.5 NC balloon at 26 atmospheres. The proximal part of the diagonal stent, which was hanging proximal LED, it was dilated with a 3.5 into 10 mm NC balloon at 24 atmosphere. Though the Zion stent of 2.5 size does not go up to 3.5, but still, since there were already LED stent strut here, so I thought that I'll dilate, and whatever LED stent crumping was there, that will also dilate in the proximal portion. So after diagonal stent was fully dilated, the flow was achieved into the diagonal. There was no dissection, distal dissection, nothing. So now the wire with whatever maneuvering, the wire had gone into LED. I tried to cross 1.0 mm semi-compliant balloon through LED stent strut, but to no avail. It was not in the true lumen. So now I removed the LED wire to be recrossed through the proximal stent strut. And the idea of reverse cullotte actually came stuck now that while I was recrossing the LED wire into the LED, it was not going. So I put the LED wire into diagonal and took the diagonal wire back into LED, since I knew that the diagonal wire in the proximal part is always into the true lumen. So that was the motive now, that the LED wire was parked into diagonal and diagonal wire taken back and then recrossed into the LED. You can see it over here. The whisper was taken back and recrossed into the LED through the strut. This. At this point, it was into the lumen. Diagonal wire was taken out, and LED sensors, they were dilated with 1 into 10 mm balloon followed by 2.5 into 10 mm NC balloon at 18 atmospheres. Since the austal proximal LED was constantly getting hit by the guide catheter, I secured it by putting a stent into austal proximal LED with 3.5 into 12 mm des at 10 atmospheres. Wire was recrossed into LED. A 3.5 into 10 mm NC balloon was taken into LED. The LED stent was totally, whole of it was post dilated with same at 16 atmospheres. And FKBI was 2.5 into 10 mm NC was taken into D1, and FKBI was done with 2.5 into 10 mm NC in D1 and 3.5 into 10 mm NC in LED at 12 atmospheres. And a final pot was done with a 3.75 into 10 mm NC at 18 atmospheres in the austal proximal LED. This was the final result. There was STIMI-3 flow. Patient came for follow-up also after 6 months, and patient was doing well with no complaints. So the discussion about it, that the incidence of stent dislodgement, it ranges from 0.3 to 8%, though with newer stents and newer designs of the stent, this incidence has actually decreased. And dislodgement of the stent can be secondary to extreme coronary angulation, a very highly calcific coronary artery, inadequate bed preparation, or when we go and do a direct stenting, or interference by previously deployed stent, which actually happened in my case. In my case, two things happened. First, breakage of the stent shaft from its softer part. And then while removing it, there was dislodgement of stent due to interference with previously deployed stent at proximal to mid LED. So percutaneous stent retrieval can be performed by various techniques. We can go with a small balloon trap technique, double wire technique, or a loop snare. And if stent retrieval is not possible, a new stent can be taken and previous stent crushed by it against the vascular wall. We have seen such cases, thereby preventing its migration. In our case, dislodged stent with a bit of softer part of balloon could not be retrieved by balloon trapping method because of previously placed stent in proximal to mid LED, where it got crumpled and elongated. And since patient was hemodynamically stable, he gave us a bit of time to intervene by recrossing the wires, maneuvering it, and performing a modified reverse cullotte. Thank you.
Well, overall, great case, Richa. Ups and downs, and finally you managed it well. Just few things. When did you first realize that your balloon is getting dislodged, and how? In diagonal.
First of all, it got broken. So when I was moving the stent to place it just at the osteo of the diagonal and keeping 1 to 2 mm, the movement got free. Initially there was resistance, but suddenly the resistance was gone. So, and because that shaft, it was coming back totally, and the stent was lying there only.
So balloon came out, and the stent was over the wire, right?
Yes, sir. Balloon was also there inside. The two markers can be visible. We can see both the markers. So first there was breakage.
Breakage of what?
The breakage of the stent delivery system, actually. With
the shaft. The
yes,
shaft.
Yes, sir.
So while you were trying to pull, it was not coming back.
Yes, sir. It lied there itself, and there was a free movement. The shaft came out. It was there in the. I saw that in the guide catheter at the top.
Shaft was broken.
Yes, sir.
So,
That actually that might have happened because while taking it was a science expedition stent. While taking it inside, I felt that something was there. I told to my scrub nurse also that stent bhi ET hone lage. This was something that, and I realized that it got broken. I don't know what actually happened, why it got stuck, because I prepared the bed adequately with a 2.2 into 10 mm balloon, but still it got broke.
So if it was broken while you were trying to remove a full unit back, so how did it come back and got stuck in the LED?
Sir, I took the LED balloon, which was already there, into the guide catheter, dilated it. Just we remove the micro catheter by trapping the micro catheter in situ intervention. So I dilated the balloon and I removed the whole assembly. I thought that the whole assembly will.
No, my question is still unanswered. So you mean to say your shaft got broken and the part of the shaft came out of the guiding and stent was still there?
Yes, sir.
So you could the shaft up till certain length, we don't know up till what length, it came out.
Yes, sir, it came out.
So that means shaft got broken somewhere with some part still in the guiding, and then it broke in the guiding and it came out. But while it was lying, some part of the shaft was lying in the guiding and stent was into the diagonal.
When I saw it, after the wire was removed and the balloon was removed and only the stent was left, when I saw it, it was a very, very small part, which might have lied into the guide. So just a second. Abhi.
Surprising. So it's a surprise that it shaft breaks off. Normally what happens, the balloon comes out of the stent and stent gets dislodged. But breaking of shaft usually happens, if at all it happens, at that point from where the wire comes out.
Right.
You know, at the monorail point.
Right.
So but it's very rare. It's very, very rare phenomenon.
That actually happened here, sir. Even if I would have, I thought of it retrospectively, even if I would have taken a snare, then also by pulling it back, the stent would have got stuck because of the proximal LED stent. The only thing is that I would not have lost the access to LED. That was one thing.
I was coming to that. So if this is a situation that your shaft came out and some shaft is in the guiding and the stent is into the diagonal, it's a very, very complex situation. And these are the things which one should try. One, have a balloon and inflate it this at a very high pressure into the guiding, trapping the shaft, if you can visualize the shaft. The problem is now shaft may not be visualized in the guiding also, so you don't know where it break off. Actually you are just playing blindly. So you only know that you trap and try to pull whether the stent is moving, it's coming back, and it moved. It has to be very strong bond to take it back, because it can slip off, and that's exactly what happened. Now once it slipped off, so I still can't understand the whole scenario. Once it slipped off, so then where was the shaft, the remaining part of the shaft?
That came out with the wire. The balloon and the softer part that came out with the wire. The whole
and stent got now dislodged into the LED stent.
Sir, actually, if there would not have been the LED stent, then my problem would have been lesser. With this trap method, the whole assembly would have come out. But because of LED stent, it got stuck there.
Right. So it's very cumbersome. It's very situation which is highly complex. But then once you land up with such a situation, then you start thinking what next, and the steps beyond that, what you thought, then it's really difficult ones, and you manage it quite well, crushing the stent and then first inflating that stent of the diagonal stent into the LED, then another stent, and then again post dilating whole of the LED. So now 2-3 layers in the proximal LED. So I don't know how it's going to behave in future, but be very stringent with the antiplatelets to the patient, and don't miss out on a single day. I would rather say give even the aspirin a double dose rather than a single dose, because patient will remain highly vulnerable for stent thrombosis even with a long term.
Patient, I discharge him on ticagrelor and aspirin, 75 ticagrelor BD, 90 mg.
Yeah. Ashish, you wish to add something?
Yes, sir. Just two quick comments. One, most of the time, whenever the stent is broken from the shaft, it happens when we are unable to cross the stent through a tight lesion. So probably the stent struts what you have dilated to balloon might not be adequate, which have led to the broken shaft. Second, what I thought while you were attempting the removal of the broken stent, you could have tried passing some polymer jacketed wires 2 or 3 into the diagonal and twist it, wrap the stent across those wires. They might not go across through the same strut, but again that might be an attempt to provide more support in attempting removal that stent across a single wire, rather than we can have more 2-3 wires with the additional layer of support.
Actually, Dr. Ashish, I've seen with this twisting of wires, usually it is a
Nothing happens. So yes, twisting of wire is not a very efficient phenomenon.
Sir, I had removed one broken piece of wire and microcatheter which were broken after wrapping them in 3 wires twice across my 5 years of
length, it was not visible, it was radiolucent. So where would I have
yes, it is that's what I mean to say. It is very difficult. It might be a simple try which will not be successful.
I think here the LED stent is providing a resistance for it to come back. So if it is lying in the lumen, it can still catch hold of that material and you can take it back. But once
we have attempted the dilatation of that strut by passing another layer of wire and dilate that strut so that it could have come easily.
Anyway, so that's a very, very difficult proposition with wires, but snare would have been one, because your end of the broken shaft was still in the guiding. So you could have deep dived the guide into the LED, and then that was one. Take the guide deep into the stented segment. There was no left main disease, nothing like that. So then try to have a snare and hold it tight and then come back. That is one method. Other than that, even the balloon trapping is not again highly efficient, because you are inflating a balloon in the guiding. Guiding is a softer structure and it's expensive. It's difficult. It tends to, whenever small resistance comes, as in your case, the resistance came in the LED stent. So then it just came out, that the balloon trapping was not efficient. So it's a deep diving of guiding one phenomena and then try the snare, or try to create a pressure with a trapped balloon. So these are the phenomena with such a thing. Another thing which was coming to my mind was, if it was so, it's better to leave a dislodged stent in a diagonal rather than handling with such a complex scenario in LED. You were lucky actually that you came out, but it was a horrible scenario. So all the points to you, Dr. Richa.
Case was managed very excellent way. Great job.
Next case.